Good morning. Thank you for coming to Grand Rounds today. I am not Dr. Robert Horsburgh. My name is David Horn. I am an assistant professor in the Division of Pulmonary and Critical Care here at University of Washington. But I'd just like to take a minute to introduce the group that has brought Dr. Horsburgh out here to present Grand Rounds today. So the Firland Northwest TB Center is a University of Washington Center of Excellence that was started in September of 2013. You may have heard of the Firland Foundation, which is a local nonprofit organization. We are separate from but heavily indebted to the Firland Foundation, who provides the support for our center. And we are a partnership between the University of Washington. We're actually housed in the Division of Pulmonary and Critical Care, as well as Seattle-King County Public Health, primarily the TB Control Program. And Dr. Narita from there is here. And our mission is to enhance interprofessional and interdisciplinary education, research, and clinical practice in the University of Washington, Seattle, and throughout the Pacific Northwest. So we're young, and in the course of developing ourselves and defining ourselves and meeting our stakeholders' needs, we have engaged in a number of activities, including an annual events, a clinical TB intensive that's held every June in conjunction with the Curry Center down at UCSF, as well as this World TB Day celebration. World TB Day was actually on Tuesday, but we're making it World TB Week. And we hope to make this event here an annual event in which we bring someone out to give grand rounds. In addition, we have some upcoming activities I'd like to highlight. This summer, we'll be starting a monthly clinical TB conference over at Harborview, to which all are invited. That will be on Wednesdays. We have an ongoing effort with the teleconferencing folks here, telemedicine folks, to develop a teleconferencing effort to support clinicians throughout Washington State in conjunction with Washington State Department of Health. And we're also looking at TB needs among tribal organizations in a 4-state region. So if you have questions or you'd like more information, I urge you to visit the website that's listed on this screen. So, I said this hopefully is going to be the first of an annual event, and I can think of no better person to kick it off than Dr. Robert Horsburgh or Bob. Bob has over 30 years of experience in public health and medicine. He is at Boston University, where he's a professor of epidemiology, biostatistics, and medicine in the Division of Infectious Diseases. He's the past chairman of the Department of Epidemiology at Boston University. Throughout his career, first at the CDC and later in academia, he has focused his research on TB, non-tuberculous mycobacteria, and opportunistic infections in HIV. He holds a number of important positions. He's been, in the past, National Steering Committee chair of 2 CDC multi-site consortiums, as well as holds a number of NIH grants, including a T32 for HIV training. Importantly, he was on sabbatical in Washington and Seattle in 1994, so some of you may know him from that time. And then last but not least, and especially pertinent to today's topic, he's currently the chairman of the steering committee of Resist TB, which is an international organization dedicated to improving MDR-TB throughout clinical trials. So I'd like to introduce Dr. Horsburgh.
Thank you, David, for that kind introduction, and thanks to the Firland Northwest TB Center for bringing me out here. It's always a treat to come back to Seattle and visit. And also, I want to say that thanks to all of you for coming this morning on a sunny morning. I got up this morning and saw the sun out there, and I thought, how can I get out of this talk? But I appreciate the fact that you're here instead of outside enjoying a rare sunny morning in March. So at any rate, my topic today, let's see if I can make this turn into a slideshow. All right, there we go, is multi-drug resistant tuberculosis. And I didn't want to be too scary about the title, so I just called it Challenges and Opportunities. But this is actually a pretty scary topic, and you'll see why in just a minute. First, I'll tell you that I do have a past of consulting for Otsuka and Janssen, who make 2 of the drugs that I will talk about. and I will also discuss off-label uses of some other approved drugs, particularly in that many of the drugs we use for tuberculosis are not actually approved for use for tuberculosis. So it's really difficult to talk about tuberculosis without talking about off-label use of approved drugs. So that's a non-starter. Okay, so I'm going to first talk about what is MDR-TB and why does it threaten global control. Then I'll talk about how we can improve diagnosis and how we can improve treatment. And then I'll talk about some of the exciting new data on new drugs for treatment of MDR-TB, and then a little bit at the end about prevention of MDR-TB, because that's really where we've got to get. But we have to go through those other stages first. We've got to improve diagnosis, treatment, and get some new drugs. Okay, so multi-drug resistant tuberculosis, just to go over the basics, is tuberculosis with disease that's caused by organisms that are resistant to isoniazid and rifampin. And isoniazid and rifampin are the cornerstones of standard TB therapy. And in fact, there's nothing quite like them, so that when you have to treat TB that's resistant to isoniazid and rifampin, you're stuck with what we call second-line agents. And they're second-line agents because they're nowhere near as good as isoniazid and rifampin. So this is a big part of the problem. This is a WHO map showing the progress. In 1994, WHO declared that TB was a global emergency, but they actually had almost no data on the prevalence of drug resistance. So they started this project, and in the last 20 years, they've actually made very good progress at defining drug resistance by doing surveys, and you can see here from the legend that more and more countries have done these kinds of surveys over time. And the more we've done surveys looking for drug resistance, the more drug resistance we've found. So it was a good thing to do, but unfortunately what it showed us is that we have a big problem. You can see here that individual cases are often not completely diagnosed, and even as recently as 2005, only 5% of the cases of TB in the world actually had drug resistance testing, and we've done a little better over time, so that up now by 2015 we're up to about 20%. But this means that 80% of the cases of TB in the world don't get drug resistance testing, so we don't even know if they're drug resistant. So a lot of the data we have are estimates based on some modeling, but they, I think, are relatively realistic. And those estimates tell us that there are about 480,000 new cases of MDR-TB globally every year. The reason we have it is twofold. Drug-resistant tuberculosis is created by inappropriate treatment, either because the wrong regimen is prescribed, or the drug supply is interrupted, and so that a person is taking not the entire regimen, or non-adherence, where, again, if a person doesn't take the entire regimen of treatment, the risk of drug resistance is quite high. We, as you know, treat tuberculosis with at least 3 drugs, and the reason we do that is if you treat with 1 or 2 drugs, you'll have drug resistance emerge. The main mechanism is just selection of naturally occurring mutations. That's the good news. That's the way it occurs. And the good news is we don't at least have what you see in enteric bacteria and other bacteria where you have transposition and plasmid-mediated exchange of resistance elements. We don't have to worry about that. Nonetheless, we have a pretty big problem just because of the creation of drug resistance by inappropriate treatment. And now that once it's created, it spreads quite well. We were hopeful early on that it wouldn't spread so well, but in fact, primary spread of MDR tuberculosis is not uncommon now because it's out there in the community and it's not getting treated, so of course it's being spread. These are the data showing the percentage of previously treated cases with MDR-TB globally, and you can see dark red are areas where over half of the TB in that country is MDR-TB. And so any of the pink ones, that's 12 or more, 12% plus, there's a lot of countries in the world with a lot of MDR-TB. And this is a really serious problem because in those countries, you're going to have so much MDR-TB that it's walking around in the community, and since we aren't very good at treating it, well, I'll come to in a minute, it is spread primarily. And here are the data on new cases. So some countries are seeing over 10% of the cases of TB that occur are MDR-TB. So it's out there in the community, and somebody comes in with TB, it's the first time you diagnose them with TB, you need to know if it's drug resistant because there's a good chance it is. And that's why we're really concerned about the direction that this epidemic is going. We're obviously doing our best to try to get people with MDR-TB into specific MDR-TB treatment programs because you can't use the standard treatment. And this graph shows that although we're making progress, so the blue dots are rising, the hope is to get to the green line, but we still are getting nowhere near the 480,000 people that we think are out there getting MDR-TB diagnosed and on treatment. So this is problem number one. We really are not doing the job. And the reason is that the resources are not there to identify and treat these people appropriately. This is what when we do treat them, this is how well our regimens work. I mentioned we call them second-line regimens for a reason. They're drugs that we discarded for treatment of primary TB, but we're still stuck with them. Ethionamide, and cycloserine, and PAS. I mean, these are drugs from the 50s that we discarded a long time ago, but that's what we have left. We have a few newer drugs, and that's what I'll be talking about later. But you can see here in the green, that's how many people have a successful outcome. And the red and the dark yellow is people that failed or died. The light yellow is people that are lost to follow-up, and then some people we don't know anything about. But you're looking at 50 to 60% success. Now, standard TB, we expect 95% success. So this is a very bad outcome. And when we're not successful, the people are still transmitting disease. So if we can't treat these people effectively, we're never going to get this epidemic under control. In addition, this is what happens. There's a recent article that shows what happens when we do our best at treatment. So this is a cohort study from 9 countries throughout the world where they actually were following people with MDR-TB at specialized MDR-TB treatment centers. And they were using the standard WHO recommended regimen. And of those who didn't have baseline resistance to the second-line drugs, this is what we saw. 11.2% acquired fluoroquinolone resistance while on treatment. 7.8% acquired resistance to the injectable drugs that we use to treat our second-line injectables. And overall, almost 9% acquired what we call extensively drug-resistant TB, and that's resistance to fluoroquinolone and injectables. So now this is what we have, a treatment program that's not very effective, and it's actually manufacturing even worse drug resistance. So this was a very chilling outcome. It wasn't expected. And as I say, this was in programs that really are fairly well resourced and experienced and using the standard recommended regimen. So we clearly have to do better than that. This is just a data showing XDR-TB treatment. And this, you can see, obviously, the countries that have a lot of MDR-TB are going to be generating a lot of XDR-TB, and the dark purple, you can see countries, South Africa, India, China, countries with not a small TB burden, have got a fair bit of XDR-TB as well. So that's sort of looming in the future. I'm going to focus my talk on MDR-TB, but XDR-TB is maybe what I'll be talking about in 5 years if we don't do a good job. Okay, not sure why that one is blank. Oh, I know. I just have to keep pushing it. Okay, so this is the summary of what we have of annual incidence global MDR-TB. We start out with, these are the 480,000 cases that we think are the MDR-TB that's out there. So the first problem we see is we're only diagnosing about a quarter of these. So that's because there's not culture capacity to go out and do the job. And this is the major problem. Major reason we're not doing a good job treating MDR-TB is we're not diagnosing it. If you don't diagnose it, you're not going to treat it correctly. But then when we do diagnose it and treat it, the number of cures that we get is also bad, and that's because our regimens are poor. So we need to focus both on diagnosis and on treatment. And what we have here is 330,000 cases that are not being found at all. So both of those are going to have to be addressed if we're going to make progress in this area. Can we improve the diagnosis? Well, we can improve the diagnosis, and we've made some steps. The GeneXpert, which undoubtedly you've heard about, is a molecular test that can detect both the fact that a person has tuberculosis and a rifampin resistance directly from sputum, and it's overnight processing. It doesn't involve expensive technology. You have to have, it doesn't involve complicated technology. It has some expense, but the WHO has actually rolled out these machines. They're all over. I have a slide in a minute showing where they are, but really globally, this was endorsed in 2010. They got special pricing, and this has really moved the field forward. It's fairly good at diagnosing rifampin resistance, and although that doesn't mean someone has MDR-TB, in most areas of the world it actually does mean they have MDR-TB. But you know right away not to put someone on a rifampin-based regimen because you know it's not going to work. And this has actually been very helpful. This is being rolled out in some countries. They use it only to diagnose people that are failing first-line treatment. Those are countries that don't have so much MDR-TB. Other countries like South Africa, they're actually using it for first-line therapy so they can identify people who've come in with primary MDR-TB and get them on the right regimen right away. This is one of the problems that we have seen is if you started somebody who had MDR-TB on the wrong regimen, you would just generate more drug resistance. By the time you realized they had MDR-TB, they had MDR-TB and streptomycin resistance and ethambutol resistance and fluoroquinolone resistance, and you're really in a pickle. So this is going to make a big difference. And these are the countries. This is the progress in rollout. And this is July 2013. They didn't put an updated slide in this year's report, but this from last year. And you can see there's a lot of cartridges being ordered in South Africa and India and China and Russia, and as there should be. I think South Africa's got 38 or 40 of these machines all over the country. It's not that difficult to get a specimen in for diagnosis. It's not a point-of-care test, but it's really helping. And it also diagnoses MDR-TB in a fairly good number of smear-negative people. So it's useful for HIV-infected people, and it's particularly good at identifying MDR-TB. So this will make a big difference. It's not going to get all the 330,000 missing people. And there is also an effort to build up laboratory capacity for standard traditional diagnosis, but this is probably what's really going to make the biggest difference. So what is our recommended treatment? The recommended treatment for MDR-TB is one that's never actually been carefully studied. It's sort of a panel of experts' recommendation. 4 second-line anti-tuberculosis drugs that are likely to be effective, and PZA, which we hope will be effective. So maybe 5 drugs. They should include a third-generation fluoroquinolone. Ethionamide, cycloserine are preferred over PAS. You treat for 8 months of an intensive phase, and then a total duration of 20 months or 12 months after culture conversion if they haven't converted by month 8. You can drop the injectable, but it really is a very demanding regimen. It takes a lot of program time. It involves a lot of effort to keep the patients on the regimen. The injectables in particular the injectables are painful, particularly in people who are thin, as many people with MDR-TB are. And as we showed, it doesn't work very well. You get 50 to 60% cures. It's a lot of toxicity. So we'd like to do better, but at the moment, we don't have anything better. So what can we do to improve MDR-TB treatment success? Well, a few things have happened, and that's what I want to talk about. This regimen, which is called the Bangladesh regimen, was developed by the TB program in Bangladesh, and they didn't do a clinical trial. They just kind of tinkered with their regimen, and they said, we've got to be able to do a better job than this WHO 20-month regimen. They developed a 9-month regimen, a 9-month regimen that starts out with 7 drugs. So this is not an easy regimen. But you have an injectable, kanamycin, prothionamide, and high-dose isoniazid, because higher doses of isoniazid are actually effective in some cases of isoniazid resistance. And they give that for an induction phase of intensive phase, which is 4 months and sometimes 5 months. And then they use gadifloxacin, a new third-generation fluoroquinolone, and they use it at a very high dose. They use ethambutol, an old standard, pyrazinamide, an old standard, and they add clofazimine, a leprosy drug. And by doing this, they've actually made some real progress. So this is the results of 515 patients treated with this regimen. They had 84.5% cures. They did have some deaths and defaults and a few failures and a very small number of relapses. So this is a lot better than we've been doing with the WHO standard regimen. And it would be great to say that this is the regimen we should now be using. Unfortunately, Bangladesh is an unusual place. There's not a lot of secondary drug resistance, and there's no HIV. And so it's not really clear how well this regimen is going to work in other populations. And it's now being evaluated in a clinical trial, and we're hopeful that we could move towards this. Although this is not going to be the be-all and end-all. It still isn't curing 95% of the people. It still has a huge number of drugs. It still has an injectable. So we'd hope to do better than that, but it would be a major step forward. It's reasonably well tolerated as well, which is kind of surprising. 21% of the people had vomiting, probably because of the ethionamide. There was a little bit of diabetes and glycosuria due to the gadifloxacin, a drug which is not even sold in most countries of the world. It was taken off the market in the U.S. because of the induction of diabetes and glycosuria. But in fact, in this study, it was not very common. It did take a little longer than 9 months to complete the regimen, most patients, but by 12 months they got it done. And people who had fluoroquinolone or PZA resistance didn't do very well, indicating that those were important parts of the regimen. Unfortunately, globally, about 10% of the patients with MDR-TB have fluoroquinolone resistance, and about 50% of them have PZA resistance. So this means that this regimen may be useful, but we're going to have to target it to a certain subpopulation of patients. There's another old drug, not old, but it came along since I started training, but it's, we've had Linezolid for a long time. We never thought about using it for TB, but in fact, it was developed as part of a drug development program which was looking to see if drugs were good against TB, and it had pretty good activity against TB. It's not been widely used for TB, the main reason being that it's fairly toxic. Any of you that have used it for staph osteomyelitis may realize that even a 6-week course can be challenging to get into a patient without significant neutropenia or neuropathy. But we now have a trial here in which it was given to patients with XDR-TB. This was a cohort of patients in Korea who were on regimens that were not converting their sputum, and we did just what we say never to do. We added a single drug, Linezolid, to a failing regimen because there was nothing else to do. We couldn't add 2 new drugs. There weren't 2 new drugs. So these patients were randomized to get 1 of 2 doses of Linezolid, 300 or 600 daily, so a hope of avoiding the toxicity, not the 600 twice a day that we give for staph. And they were further randomized to immediate versus 2-month delayed. So nobody got placebo. It wasn't felt to be ethical. But you can see the difference between the arms by just looking at the delay. And the outcome was excellent. 36 out of 40 converted their sputum cultures. There were those ones that didn't convert, did develop resistance to Linezolid. No surprise, just how we'd like to develop. If you wanted to develop resistance, that's what you'd do. You'd add a single drug to a failing regimen. Here you can see, though, this is really a phenomenal result. So this is the immediate start group, and right away people start converting their sputum, and up you've got over 90% of these patients who had not converted their sputum on everything we threw at them, then did so on this drug. And the delayed start group didn't have any conversions, and then once we started it, they saw a similar path. So this actually indicates that while it's not the easiest drug to use, it has a fair bit of activity, and it might be something we could include in a regimen for patients with MDR or XDR-TB in particular, given that we don't have a lot of other options. This is the tolerability in another similar study, but larger numbers. So peripheral neuropathy seen in about 40% of the patients, and anemia, 25%, optic neuritis, and 10%. You got to stop the drug if you get that. The others will go away if you stop the drug. If you continue with the optic neuritis, it's a very bad outcome. So we don't do that. But thrombocytopenia, GI disorders, neutropenia, there's a lot of toxicity associated with this drug, but it does work. And so we're talking about treating a disease on which we don't have many options. This is one that we need to keep on the table. So what about new drugs for MDR-TB treatment? There are a bunch out there. This is the global TB drug development pipeline, and this is actually a modified version of the one that's on the website. And the reason it's modified is some of the drugs that they had on their slide are already off the table. We found they're too toxic or not effective. But what we still have to work with, if I get the pointer to work, is, so we know about gadifloxacin and moxifloxacin. Rifapentine is a drug which may be useful for a drug susceptible to TB, but it cross-reacts with rifampin. So for MDR-TB, we can't use it. But we have 3 new drugs. Where's my pointer again? Delamanid, Pretomanid, and Bedaquiline. And I'll talk about each of those, and because we have a lot of very interesting new data, and 2 of those drugs are actually licensed in various parts of the world. What we don't have here, and it's important to point out, is anything in phase 1. We got a lot of very interesting drugs, none of which have names because you don't get a name until you get past phase 1. They're all number drugs, and they all look very interesting, and many of them are totally new classes of antibiotic, but none of them have gotten into clinical trials, and there's a real gap here. There's a challenge in getting drugs into clinical trials. Venture capital is not going to put these drugs into clinical trials because they are not going to make any return. TB is not the kind of place where you're going to make have a blockbuster drug from a fiscal point of view. It might be a blockbuster drug from a patient point of view. But so there's a real challenge here, and it's something that needs to be addressed. People are concerned about this right now, and we're not quite sure what the answer is going to be, but it is a major stumbling block. Fortunately, we have these 3 drugs, Pretomanid, Bedaquiline, and Delamanid, which have made it past that barrier, and so I will talk about them in the coming slides. So Bedaquiline is the first one. It used to be called TMC-207, just in case anybody's been following this. It's a brand new class of agent. It's called a diarylquinolone, and it works by inhibiting the proton pump for ATP synthase, which is a new mode of action. It has a very long half-life, and so it actually has a lot of the things we'd like to see for a TB drug. It does cause a little bit of nausea, but the main issue we have here is the thing called QT prolongation. So this drug prolongs the QT interval, which in itself isn't a problem, except if it prolongs it enough, it can lead to induction of cardiac arrhythmias, and a particularly bad one called torsade de pointe, and that can cause sudden death. So we are concerned about this. We don't want to be doing that, but we're looking very carefully at this drug. The chemical structure, for those of you that are interested, is there. You won't be tested on it. This drug has been through a number of clinical trials. The first one was a phase 2 study in which bedaquiline was added to an optimized background regimen, so people on MDR-TB with all those old drugs, and then either the bedaquiline or the placebo was added for a 6-month treatment regimen, and Janssen Pharmaceuticals did this study, which is why it got past the phase 1 stage. It had a pharmaceutical company behind it. The target population was people with MDR-TB, either with or without HIV, and the outcome was time to sputum culture conversion. And what we saw was this. This is the background regimen, so a much slower conversion of the sputum. So 50% conversion here, you can read it, in about 18 weeks. Whereas when the bedaquiline was added to the background regimen, about 12 weeks. So a substantial improvement, not the 95% cures that we'd like to see, but a very, very big step forward. This was very exciting news, and we're happy to see it. This just summarizes the results, median conversion 12 to 18 weeks, but also the overall treatment. Even though they only got the bedaquiline for the first 6 months, and they got treated with a tail of 12 months of the other drugs, at week 120, you had 58% cures in the bedaquiline-containing arm and 32% cures in the placebo-containing arm. Not much difference in serious adverse events. So this really was a major step forward, a great new drug, and we're happy to have it out there. Unfortunately, the other thing that happened, I think it's on the next slide, is, yes, so we did see QT prolongation, 15.4 milliseconds in bedaquiline versus 3.3 milliseconds in placebo. That in itself is not a terrible number. I'm sure this is not the kind of number, but you worry about 30 or 40 or above, but it's pretty substantial. However, the other thing that this trial showed, that at 120 weeks, There were more deaths in the bedaquiline arm than in the placebo arm, a statistically significant difference, and this has tempered the enthusiasm for the use of this drug. Other than these, there weren't any differences between the bedaquiline and the placebo arm in terms of toxicities. So we're left kind of stuck, and right now this drug is approved in the United States, but it has a black box warning that says, don't use this if you have other options, basically. It says, if you have to use this drug, you have to use it, but we're really concerned about this. There is now a follow-up study about to go in the field to see if this was a statistical aberration. They look carefully at all these deaths. None of them seem to be sudden deaths. People have been off bedaquiline for a year and a half. I mean, the drug has a long half-life, but it's out of the system by then. But it still is something we have to address. And I think the only way we're really going to get the answer is the follow-up study, and that, as I say, is in progress. So it's tempered the excitement about bedaquiline. And the current WHO recommendations, WHO has issued recommendations that they say use it for patients with MDR-TB, but only when the isolate is resistant to fluoroquinolone or the injectable or both, so XDR-TB or pre-XDR-TB. In other words, when you don't have other options. And you may also, or if the patient is intolerant to fluoroquinolone, the injectable. Again, give it only for the first 6 months, but it seemed to work pretty well that way. And then continue the other drugs. So this isn't shortening therapy, and they also say don't use it with Delamanid because that's one of the other new drugs, and it has a QT issue as well. So we really are, unfortunately, running into some issues here, but nonetheless, it's great to have this drug available. I have used it already in a patient who showed up at our hospital in Boston with XDR-TB. You never know what's going to happen, but he just got off a plane from India, and there's a lot of XDR-TB in India. So we did need it, and we could get it. It's not cheap. It's not easy to get, but you can get it. It is actually only available through, I believe, the state health department, or there is a central place in each state. So if you need it, talk to Masa. He'll find out who you need to talk to. Have you ever gotten it here in Washington? No. I mean, there isn't that much need in the United States, but we had it. We needed it, so you can get it. There's only been a handful of patients in the U.S. that have received bedaquiline. Okay, what about Delamanid? Well, that's Delamanid. That's its name and its number, what it used to be called. It's another new drug class, different from the diarylquinolone class. So we now have two new classes, and this is really exciting. It's called the nitroamine azoxazole. These are, you remember, Flagyl are. These are congeners of Flagyl that are more active against TB. They inhibit mycolic acid synthesis, which basically inhibits the ability of the bacteria to divide. They have also a reasonably long half-life, but they also cause QT prolongation. So this is another issue, but this drug also made it through to phase 2 trials and is currently in a phase 3 trial because it's also sponsored by a pharmaceutical company, Otsuka. And this study, it was their first study. They did a similar design. They took people with MDR-TB, they gave them an optimized background therapy, and then added Delamanid at one of 2 doses or a placebo. And this was a shorter study, only an 8-week study. And what they found was that either in liquid culture on the top or solid culture on the bottom, either dose of Delamanid was better than placebo, substantially better. And this translated into more culture conversions. But this was a short study, so they didn't actually have long-term outcomes. And so they have another study in the field in which they're looking at long-term outcomes, but this is a magnitude of effect similar to the bedaquiline effect, and we expect that this will translate into more cures and fewer deaths and failures. Is Delamanid well tolerated? Relatively well. Smaller increases in the QT interval. They were 15 with bedaquiline. They're only 7.6. But up to 12 at 2 months, and that's all we have. 3% of the patients did experience an increase of 60 or greater, and that's very worrisome. One patient went over the total of 500, and that it resulted in his being taken off the drug. There were no sudden deaths, and there weren't long-term outcome data, so we don't really know what that did result in terms of death imbalance. This drug has been approved in Europe, but not in the United States. I think an application is being made. But it is, again, the WHO has a similar recommendation to only use it for patients with MDR-TB where the isolate is resistant to fluoroquinolone or the injectable or both, or intolerant, again, to give it only for the first 6 months and continue the other drugs and don't use it with Bedaquiline. So we have 2 drugs out there, both of which might be useful, but you can't use them together. And, of course, what we like to do, we like to use them together, but we don't know yet whether that's safe. Both of these drugs are only available. Delamanid is available in Europe and in Japan, and maybe in Korea, and Bedaquiline is available in the U.S. and in Europe. And the Bedaquiline folks have actually made more progress in terms of at least applying for registration in some of the countries where it matters, like India and China and South Africa. The Otsuka people haven't yet, but the Otsuka people are a little farther behind because their drug, they don't really have good 6-month data on it yet, and yet are recommending it be used for 6 months. So those data are being developed. The third drug I want to talk about is called Pretomanid. Now, this is a nitroimidazoxazine, so it's different from Delamanid, but not very different. So this is not really a new class of drug. This drug will cross-react. Resistance to this drug will mean resistance to Delamanid and vice versa. So we really only have 2 new classes, even though we have 3 new drugs. It's also a mycolic acid synthesis inhibitor with a relatively long half-life. QT prolongation, it probably has it as well. We don't have good data. This drug is a little farther back in the pipeline, and we've got to look and see, but my guess is it's probably a class-specific effect, so it wouldn't surprise me. This drug is being moved forward. This drug was developed here in Seattle and not taken forward, and the Global Alliance for TB Development, which was funded by the Gates Foundation largely, has picked this drug up and is acting as the pharmaceutical company that's sponsoring and moving this forward, and it's been very successful. Their largest study was just recently published in Lancet last week, and this is a drug when they studied it in combination, so a different design, moxifloxacin, PZA, and Pretomanid, mostly in drug-susceptible patients, but the red line is in drug-resistant patients. And you can see that it seems to have a pretty good effect. The blue line, they told me this would happen if I used that pointer. Okay, so the blue line is people with drug-susceptible TB treated with standard regimen of isoniazid and rifampin. So that kind of gives you that's what you'd like to do. And you can see the MDR-TB patients did just as well on this new regimen, the red line. And so that's very promising. The caveat is these were patients who were pre-selected. We knew they did not have resistance to fluoroquinolone. That's why they could be given Moxi. They did not have resistance to PZA. That's why they could be given PZA. So this is not going to work for everybody, this regimen with MDR-TB, but it will work for a substantial minority of them, and it could be a very useful regimen. This regimen is about to go into a trial of a 6-month treatment. And so this is very exciting, but we won't have answers for a while. But again, a regimen of new drugs that might give us a rifampin-free treatment regimen in 6 months that might work for a substantial minority, but a substantial minority of the patients with MDR-TB. So what is happening? There are a lot of clinical trials in progress. 7 or 8 years ago, when those of us who are interested in MDR-TB got together around a table in a restaurant at the end of the Union TB meeting, we sort of bemoaned the fact that nothing was happening in MDR-TB. Nobody was doing clinical trials, and we decided to get busy, and we formed this group called Resist TB, and we went out and beat the drums, and people heard us. There is a lot now going on in MDR-TB clinical trials. I'll talk about 5 trials that are in the field right now or about to start imminently. And they are the Phase 3 Delamanid trial, a trial called the STREAM trial, which is studying the Bangladesh regimen in a more systematic way, a trial called the Opti-Q trial, which is looking at higher doses of levofloxacin for MDR-TB, a trial called the STAND trial, which is the one using Pretomanid and Moxi and PZA for 6 months, and then a trial for patients with XDR-TB in which Pretomanid and Bedaquiline are being used together. We don't have enough data. The WHO doesn't say not to use those two together, so this would be a trial that could, in fact, be very useful for people with XDR-TB if there's not a lot of QT toxicity. So the Delamanid trial has actually been going on for a while, and this is where they add Delamanid to an optimized background regimen for 6 months, just like Bedaquiline, and then they follow with an 18-month tail. So it's not going to shorten treatment, but it might make treatment better. It's being sponsored by Otsuka for adults with MDR-TB. The trial is 100% enrolled, so we're just now in the follow-up period. And so we should have answers by next year to know if adding Delamanid to the standard background will improve cure rates. I suspect it will, and this will hopefully then move Delamanid forward, and unless we get tripped up by some death imbalance, which I hope won't happen, this might make a new drug much more widely available for treatment of MDR-TB. The STREAM study is a very interesting study in which they're comparing the current WHO standard regimen. This get the pointer again? Okay. That's the standard regimen, 4 to 5 drugs for 18 to 24 months. And the Bangladesh regimen is this one here, the 7-drug regimen. They have modified it because you can't get gadifloxacin anymore. They're using high-dose moxifloxacin instead of high-dose gadifloxacin. And so the goal here is to see if a 9-month regimen works in places where there's HIV, in places where they're not like Bangladesh. Because basically, this is being done in Ethiopia, Vietnam, South Africa, and they were just recently added a site in Mongolia. So we're getting a lot of geographic diversity, but it will tell us if this is a robust regimen, and hopefully that will lead to this replacing the 24-month regimen. This would be wonderful because then your program staff isn't tied up trying to treat people for 24 months. At least if you can get them treated by the end of the 9-month regimen and by 12 months, it'll be and the cure rates were around 84%. So if they stay that way, this would be great. But there was a lot of uncertainty about whether that would happen, so this has been subjected to a clinical trial. And the trial should be completely enrolled early this year, and then we will have to follow people because of the 18 to 24-month arm. I actually don't think we're going to have results until 2017. So it's exciting that that's out there. It is unfortunate that these trials take so long, so we're not going to have an answer anytime really soon. The Opti-Q study is a smaller study that we're actually doing in South Africa and Peru, in which we're looking at higher doses of levofloxacin. There's good evidence that levofloxacin is being underdosed for TB, and therefore we might have a more effective regimen if we used higher doses. And levofloxacin, unlike moxifloxacin, levofloxacin has no QT problem. Moxifloxacin actually has a QT signal, just what we needed, and we're trying to combine this with these other new drugs. So levofloxacin would be a better drug if we can find the optimal dose. This is another example of things that never got done that we should have done 20 years ago. If we're going to use levofloxacin for TB, we should have figured out what the right dose was. But we didn't. We just took the doses that we use for serious bacterial infections and started using them, and they're probably too low. But this study is only going to enroll 100 patients, and we expect it to have answers also by 2017. The STAND trial is the one I mentioned, in which they're going to look at that regimen of Pretomanid, moxifloxacin, and PZA in people with both drug-susceptible TB, and they have one arm here for drug-resistant TB. So this, back you go, okay. This arm here is for, wait a minute, okay, back, okay. There is an arm for drug-resistant TB, here it is, the last one down, MDR-TB, that is fluoroquinolone and PZA susceptible. So we will hope that this is a successful trial and that it shows, there's several things it could show. It would be great if it showed that a 4-month regimen was good for drug-susceptible TB. But from my point of view, the most important thing is if it shows that a 6-month regimen with these 3 drugs is good for a subpopulation of people with MDR-TB, we'll then have a 6-month regimen we can offer to them, and that will be a very important step forward. But this trial is starting now. They haven't yet enrolled a single patient, but they're out there looking for sites and getting regulatory approval. This trial I mentioned as well. I didn't mention, this is the trial for XDR-TB, and this is a small trial in which they're going to use 6 months of Pretomanid and Bedaquiline and Linezolid. So 3 new drugs because they're trying to treat XDR-TB. So this could be great. It also could be really toxic. So we really don't know. It's a very small exploratory trial. They're going to do it only in South Africa, where there's plenty of XDR-TB, and they're hoping that in 6 months they'll get cures, but it's going to take a while to do this one as well. So again, by 2017, should be an exciting year. There are other trials that are in preparation. So we have kind of an embarrassment of riches, but the sad part is there's no shortage of patients with MDR-TB, and that's why it's possible to do all these trials. So the next trial is a trial that's being organized in South Africa to look at Bedaquiline and see if we can get a regimen of 6 to 9 months without an injectable agent, which would really be less toxic and hopefully effective. And if the black box warning comes off, then this trial will have demonstrated that we'd have a 6 to 9 month regimen with a Bedaquiline backbone. The STREAM study is going to add 2 arms with Bedaquiline, looking at a similar question: can you remove the injectable? So they're going to have a 6-month regimen with Bedaquiline and an injectable, and a 9-month regimen with Bedaquiline without an injectable. So those 2 trials are going to look at similar things. The STREAM trial would be done in many other countries, so they'll be complementary and helping us understand how to use Bedaquiline. The ACTG, the AIDS Clinical Trials Group, has a trial, which is a very important trial, which is going to look at using Bedaquiline and Delamanid together and see whether the QT problem is really a serious one. We'd like to get that restriction removed, but there's no way to know that other than doing a very carefully monitoring these people for QT and seeing if these are additive or multiplicative, and do we have any bad outcomes. So a small study, but it's going to, in the field, probably in the next 4 months, to look at drug-drug interactions between those 2 drugs in people with MDR-TB getting an optimized background regimen. Another trial that the Global Alliance is putting together, called NC005, is a study we're looking at Bedaquiline and Pretomanid. Instead of for XDR-TB, it'll be for MDR-TB, and it's an 8-week phase 2 study to see if what combination, what doses are optimal for MDR-TB. And then there are 2 other trials that are being organized. The TB practical trial, Médecins Sans Frontières, sees a lot of MDR-TB patients. This trial will be done in Kazakhstan, and they're going to look at a Pretomanid Bedaquiline containing regimen also, but different regimens that are in the NC005. And then the NiX-TB Trial, which is being organized by Partners in Health and also some collaboration with Médecins Sans Frontières. And Partners in Health, of course, also is active throughout the globe doing MDR-TB treatment. And this trial will be looking at 4 drug regimens that are built either on Bedaquiline or on Delamanid using clofazimine and Linezolid and moxifloxacin or levofloxacin. And again, trying to come up with either a 6 or a 9-month regimen. So this is where the field is going. We have new drugs. We're not sure if they're safe, and we have no idea how to use them to optimally treat MDR-TB. So the goal is to come up with 6 to 9-month regimens that will enhance our ability to treat these people. And of course, we're awash in patients, so we're going to have to roll these out into programs so we can get all of these patients that we're now starting to diagnose treated. What about prevention? It always comes last in the talk, but it is very important. But we kind of got to, fight the alligators before we clean up the swamp. So we need to ensure that treatment is completed to prevent emergence of resistance, and better regimens will make a big difference. We will create less secondary MDR-TB if we treat people with better regimens. So if these new regimens are really robust and are able to drive the bacterial burdens down and achieve cures quickly, then that will help us with preventing emergence of MDR-TB on treatment. We also need to get out in the community and find and promptly treat the MDR-TB cases to reduce the primary spread in the community. That's the only way we're going to prevent this from happening, is getting the people who are out there walking around coughing very easily transmissible MDR-TB organisms into everybody's face. And there's a lot of parts of the world where that's happening not infrequently. And then lastly, it would be terrific if we could do what we do for drug-susceptible TB and go into the households of patients and find who's converted their skin test and give them a prophylactic treatment. We know how to do that for drug-susceptible TB. It works either with INH or rifampin. Neither of those is going to work for MDR-TB contacts. And therefore, there is some people are now starting to look, and there's at least one study being organized to see whether treating contacts with a fluoroquinolone, in this case levofloxacin, would be effective. We have no idea how long we should treat people, and they're going to take their best guess and do a trial. But at the moment, we have no treatment regimen that can prevent MDR-TB in people who are infected but not yet having disease, but at high risk for going on to get disease. So in conclusion, it's very exciting. We have new TB drug classes. They may increase the treatment responses. They may shorten treatment duration and decrease mortality, but we don't know that yet. And we need to find out as soon as possible. The other side of the coin is the tolerability of these new and the repurposed agents, and I didn't even talk about the tolerability of clofazimine, but it's not an easy drug to take either. That remains to be defined, especially when they're used in combination, because the QT toxicity in particular is common to a number of these drugs. And there are combination studies underway to assess drug-drug interactions between the new agents, particularly the ACTG trial, which will look at Delamanid and Bedaquiline, but also interactions with other TB drugs and with antiretroviral therapy, because a lot of the patients with TB, with MDR-TB, have HIV as well. That needs to be treated at the same time, and so that complicates the treatment regimen, because you've got to get a good, effective antiretroviral regimen in addition to a good and effective anti-MDR-TB regimen. So I will conclude with an advertisement. If you're interested in this area, go to the website of Resist TB. There's a lot of information there. We have a monthly newsletter of both news and articles that we're happy to send to people. And if you go to the website, you can just give us your email. We're happy to send it around. But we are doing our best to raise the alarm and move things in the direction of getting this issue resolved. I'm happy to say that the WHO and other organizations have taken up the fight and are indicated that this is a major health priority, and we need to get more resources to address it. So that's the end of my talk. I'm happy to take comments or questions, whatever people would like to know that I didn't say.
Thanks, Bob. That was super. This QT prolongation issue is a real nuisance. We see it in the ICU. We see it in the TB clinic, et cetera. You showed several of the molecules that, represent these new drugs. Is there any way to modify those chemicals so they wouldn't prolong the QT, but they would still kill the MDR, XDR-TB?
I don't know, and from my talking to people, other people don't know either. This is a new area. It was always recognized that certain drugs, like, for instance, moxifloxacin, Bayer knew for years that moxifloxacin had a QT effect. That's why they didn't want it used at any higher doses. But it was small enough that it wasn't clinically meaningful. But basically, if a pharmaceutical company finds a drug that has a QT effect, they just drop it. And this is one of the reasons that some of these drugs never got moved forward for TB. Now, the sad news is that for MDR-TB, we put up with it. It'd be nice if we didn't have to. But the mechanisms are totally not understood, and that's why we can't predict whether using two of these drugs together of different classes are going to be additive, or we don't even know. Maybe they'd be subtractive, but we don't know how they work. So it's a total black box. And the reality of it is there are a lot of drugs out there that do prolong QT interval. Most of them are ones that are not commonly used. Many of them are cardioactive drugs in the first place. But it's a risk. Now, we worry a lot about QT prolongation. Torsade de pointe is incredibly rare, but we don't want to make it more common. That's what it boils down to. I mean, none of the deaths that occurred in the Bedaquiline trial looked like they were that. They weren't people driving a car and dropped dead of a heart attack, but they died for one reason or another, and that the FDA says is not a good thing. I agree with them, so we need to sort that out. Yeah.
Thank you for an interesting talk. I'm curious about the economics of this from the pharmaceutical company point of view. In other words, Janssen and Otsuka are involved, and this is a disease that occurs predominantly in poorer economically speaking countries, and but yet they're developing new classes of agents, apparently. And why are they doing that, and how do they expect to get a return on investment?
Right. So that's a good question, and it's really sort of a minor miracle. But in 2000, the Gates Foundation convened a group of people in Cape Town, including a number of pharmaceutical companies, and really said, please help us out. We need some new TB drugs. Have you got anything on the shelf that we can deal with? And so people looked around, and that's how the Global Alliance ended up with Pretomanid. But Otsuka found this drug that they thought might be useful, and Janssen had this other drug that they thought might be useful. And really, it was because of two very dedicated people, one in each company, that moved it forward. One was the scientist who developed TMC-207, and he really pushed, and literally the drug was nearly dropped several times. So they didn't do it because they thought they were going to make money. Otsuka is even more interesting study. Otsuka was a privately held company until just very recently. And the president of Otsuka, Mr. Otsuka, had family members who had TB, and he wanted to do something for TB. And according to the people I know in the company, they said every year the CFO would come to him and say, we've wasted enough money on this drug, let's drop it. And he'd say, no, we're not doing that. So they've both developed the drug, but they know they're not going to make any money. They're not going to do any more studies. They've made it available, but the studies are going to have to be done in the public sector. The studies that they are doing, the two that I mentioned, are being done for regulatory reasons. They wanted to get the drug approved. And right now they have conditional approval, so they have to do these follow-up studies as part of the conditional approval. Once they get that done, they're washing their hands of these drugs because there is no money to be made. And that is the bottom line. And I don't know if that miracle is ever going to be repeated. That big gap in phase 1 studies, which is first in man, we call that the valley of death, because drugs can't get across the valley of death without a huge infusion of capital, and that generally is the result of venture capital, and venture capital doesn't do that unless they think there's a reward at the end. There's no pot of gold at the end of the rainbow with any of these drugs. So we're really stuck right now, and it's wonderful to have these 3 new drugs, these 2 new classes, but I think that's all we're going to have for a while, and that's the problem.
Thank you very much. Please feel free to come forward if you have any further questions.